All right, welcome to our first quarterly meeting for 2025, which seems just shoo to say it out loud. How did we get this far into life, right? This morning, our agenda, what today looks like is we're going to have our speaker, Joshua Stegemeyer from ADHS, talk about the suicide prevention efforts in Arizona, which are really quite extensive and really great resources out there. We will then have our committee and partner updates, our board updates, and we will do some announcements. And one of those is really kind of picking your brains to what you would like to see the summit for 2025, our 12th annual summit, look like this year. Because as you know, we really want to bring what you guys would like, right? Not what we think is best. And so I really would love your input in those pieces. So without further ado, I will stop sharing and I will pass this over to Joshua and we can get started.
All right. Well, thank you, Angie. And one of the things we're debuting here, y'all are one of the first to see it, at least from my presentations, is the brand new Arizona state branding. So we've got a brand new color palette, brand new slide deck templates and everything. So for myself, I really enjoy the new colors. But without further ado, we'll go ahead and get started. Here you can see our agenda. We're going to go through the state of the state with a data update, and I have just finished adding in the new 2024 data. So those data are provisional. They are subject to change before finalization, but this will give you a good idea where we're at as we close out the 2024 data and start to look at, what happened last year and how can we analyze it. We'll then go through our suicide mortality review, which has been going through a lot of upgrades and changes, and we'll kind of explain what that is, how that works, and some of the exciting new developments, and go through some of our other work that we've got going on as well. So lots to talk about today. All right.
Josh, is there a way to turn up your volume? You're really kind of quiet.
Okay, how about now?
There you go.
All
Yes.
right, sorry, sometimes this boom mic's a little too directional.
No worries.
All right. So here on this first slide, we have a couple of different data tables. The one on the left talks about Arizona suicide deaths and rates of death per 100,000 of population. And the one on the right talks about that same data, but for age groups. And both tables attempt to compare data. The first one here, you can see it compares Arizona and national data from 2018 to 2024. And the other one compares 2024 data to 2023 data. Okay, and so looking at some of these key observations, young adults 18 to 24 experience a significant increase with deaths rising from 123 in 2023 to 166 in 2024. That rate increase went from 17.3 to 23.3 per 100,000 of population. So that's a significant increase. And this is a good place for me as we start to talk about these things to remind everyone that while these are numbers and we have to talk about things and quantify them, that each one of these numbers represents somebody's life, somebody's story, and that these are people's stories and not just statistics. So we'll invite everyone to remember that as we go through here. Um, some other key observations from these slides. Older adults, 85 plus, one of our highest rate groups for a long time now, saw a dramatic decline from 65 deaths in 2023 to 39 in 2024. So that's a pretty significant rate drop of almost 40%, 45% there if you do the rough numbers. Middle-aged groups continue to have some of the highest suicide rates, reinforcing the need for supported prevention in this population. Um, there we go. Let's see here. As I scroll through some of these here. Yeah. So the only other thing that I would point out here is just that where Arizona sits, you can see that we've had a drop in 2023 on the table on the left there near the bottom, and then again in 2024 with our provisional data. However, we don't currently have numbers to compare that to at the national level, and that's not because we don't know how many people died by suicide. We do. It's just that right now, currently, with a lot of what's going on in the federal level, and even what was going on at the last year, we don't have the population data to be able to do the math to have our rate. And so while we know what our Arizona rate is, we don't have that comparison for the United States. So that's the reason for that discrepancy. As we move on here to some of our select demographics, you can see the comparisons from 2024 to 2023 again. Green indicates that there was an improvement, and this kind of a burnt umber is that maybe a darker orange is indicates the need for improvement, right? The numbers went the opposite way in this comparison. So some of the key observations from this are that these data presented provide a comparison of deaths from 23 to 24, and that these numbers reflect the need for targeted prevention efforts. So the American Indian and Alaska Native population has seen another decrease. And this is important because these numbers in that community have been declining since 2021 when they were at a record high. So that's good news, although there's still more work to be done. You can see that out of the racial and ethnic demographics, they're still the highest risk, but things have been improving steadily for the last 4 years now, and we hope they continue to do so. More worrisome, if we look at the data, are the Asian American and Pacific Islander numbers, which deaths increased significantly from 19 in 2023 to 44 in 2024. So that moves them from our least at-risk group to moving it more towards the center of the center mass for our groups. A piece of good news is that Black and African American suicides, deaths by suicide, have been rising since 2019. Well, we had a fairly significant decrease from 2023 to 2024. So hopefully that trend continues to hold into next year, because they had gone from, again, like with the Asian American and Pacific Islander population, from one of our least to much more at risk. So across the white Caucasian population, you can see a slight decrease there, and more significant increase among the Hispanic and Latino populations. So kind of a mixed bag of results there from 2023 to 2024. We're statistically about the same in our deaths and rates of death by suicide. So not a surprise that things would be, somewhat of a mixed bag there. One change that's again important to point out is that our veteran deaths by suicide have continued to decrease over the last couple of years. So, as always, when it comes to the LGBTQIA2S plus population, I have to point this out, that while we do not have data to indicate the risk level here in Arizona, we do know from national level research and research here within Arizona that the individuals who identify as LGBTQIA2S plus are at an increased risk of suicide. So we don't have that data. It is important to remind folks of the risk, and that the community needs some extra support for those individuals. All right. Move into some county level data here. We have some improvements and some things headed the other way, so we'll talk a little bit about that. Suicide risk is not evenly distributed across the state, and I think that is the story that the data on this slide are telling. Right, some counties experience higher rates, some lower, and this can help us target the prevention efforts where they're needed. So, some key observations: La Paz has the highest rate of death by suicide in our state at 53.3. Um, Deaths remained at 9 from 2023 to 2024, so you can kind of see the indication of their small population. But though it's small in population, La Paz has a persistently high suicide rate. So this is across years and across sort of different things like COVID, not COVID. Um, the time before that, La Paz has been struggling. Apache County, while down, is still very high at 43.3. And Mojave Mojave County, well, they've made a lot of improvements in their SMR program in particular is doing very well. There's still one of the highest rates in the state and indicating a need for enhanced health support, crisis services, and community outreach across not just Mojave, but northern Arizona as well. Moving more towards central Arizona, Yavapai County increased from 32.9 per 100,000 to 35.8. And this rising rate suggests an increased need for prevention efforts, but particularly among aging populations, as Yavapai has one of our most significant older adult populations in the state, along with Mojave County. Graham County, this is down in southeastern Arizona there, their rate also increased. And again, although it's a small population, um, it's concerning because there's not a lot that we can do out there. We have to emphasize the need for accessible mental health service access and some of those other community and crisis outreach services. Talking some good news, some counties with some notable decreases in suicide rates. Cochise County dropped significantly from 32.2 in 2023 to 15.7 in 2024. So that is a very dramatic rate, almost actually that is more than half, right? We're going from 41 deaths down to 20. So this is very promising, and it indicates some successful efforts. Everything from the Garrett Lee Smith grant that's going on in Cochise County right now to their excellent work in their SMR. But we have to make sure that those efforts continue so the rates do not rebound down there. Navajo County also saw some significant improvement from a rate of 42.8 deaths by suicide per 100,000 in 2023 to 26.4 in 2024. So yeah, but Navajo County remains a high priority area, being in that sort of super at-risk area across northern Arizona there. Pima County, while the rate decreased very slightly, it's a really good story of success that it's not rising, given some of the challenges southern Arizona is facing and the current environment. So urban mental health services remain critical down in Pima, and with the launch of things like Teen Lifeline's new center down in Tucson, we can continue to address those needs. Yuma County, they had one of the highest rates a few years ago in the state, but once again, it declined. There's a lot of good efforts going on out there through the health department and stakeholders. So that's a community-based support showing up to be a protective factor there as a lot of folks get on board to try and reduce the suicide rate even farther. Some important differences when it comes to urban versus rural. Maricopa and Pima counties, Arizona's largest metro areas, have lower suicide rates than many rural counties. Um, Rural counties, most of them are showing consistently the highest rates of suicide across the state. One of the talking points, though, is that with Cochise able to get down to the level of our more urban centers, there may be a pathway for success that we're seeing in some of our rural areas to reduce that suicide rate. Um, but in general, our rural areas continue to face the highest suicide burden, likely due to limited access to mental health services, social isolation, and economic stressors. So, partnerships with local providers, community groups, and crisis response teams are really important for addressing these disparities. Um, and that suicide prevention must be community driven, data informed, and culturally responsive to meet the unique needs of each county. As you can see here, there's quite a bit of differentiation. Last thing I'd like to point out before we switch this slide is that you'll see on here there's some S's and some sixes and less than six. So just to clarify that, six is our threshold of the number of deaths of suicide in order for us to release the information publicly. We don't want to get too identifying by releasing information lower than that, and that's what the S is. If you see an S on the data table, that means the number was less than six. If you see the less than six on the actual county map, that's the same thing. There just weren't enough deaths by suicide for us to release the actual number. Okay. Moving on to a little bit different data source here. All the data that I just reviewed comes from the Arizona Department of Health Services. Some of it's from CDC population data, but the vast majority of it's from vital statistics and death certificate data combined with our population information for the state of Arizona. What we're looking at right now is something different. This is the National Syndromic Surveillance Program as it relates to suicide. Now, the NSSP is a program run by the CDC, and they collect information from around the nation, from hospitals, clinics, inpatient psychiatric facilities, and then they publish this syndromic surveillance for all kinds of different health concerns. What we're looking at is the data for their suicide surveillance. And this is really important because this is the closest thing to real-time monitoring that we have. These numbers are reported in a lot of cases up on our dashboard within 24 hours. And so you can see sort of where some of the hot spots are, at least when it comes to some of these items down at the county level. So you can see what the emergency room totals were for suicidal ideation attempts and what the totals are. And the same thing for inpatient. Inpatient refers to inpatient psychiatric facilities and also like long-term residential treatment for substance use disorders. And emergency room includes not just the emergency room, but also like urgent care clinics and such. So all in all, 90% of all clinics and hospitals and facilities report into the CDC Syndromic Surveillance Program. There is one notable gap, and it's a big one. We only have one IHS 638 facility that reports into the syndromic surveillance. So when it comes to the tribal nation data, in a lot of cases, it's not reflected in the syndromic surveillance, but pretty much everywhere else in Arizona is. Couple of things that I would point out about this. One of the really important things is that while the numbers are still very high, there's a decrease in emergency room visits for ideation and attempt. That's great. And that's one thing that I want to point out. It's really important that we continue to see a reduction in emergency room visits for ideation and attempt because those aren't the best places for people with suicidality to go. So we want to continue to see those numbers decrease. Now, in the short term, that means that our inpatient numbers might actually increase. And that's kind of what we see as people are maybe being redirected out of the emergency room through our crisis system and maybe getting more into inpatient care, right? We also want to see the number of attempts reduce. And in the short term, maybe the number of ideations increase as we work to identify folks before they get to the level where they're attempting. Maybe we can catch it a little bit earlier in ideation. So if you look at these indicators, fewer attempts, more ideation, less emergency room, more inpatient, we can kind of see that the syndromic surveillance is painting a picture where more people are getting help sooner. And that is what we really want to see. So while these numbers are still what they are, we can't change the fact that over 26,000 people went to the emergency room for suicidality last year. Yes, Angie.
One of the questions in the chat is, what is the definition of ideation that qualifies for being counted here?
Okay, so ideation in this sense is that a clinician has made the determination that they need to be receiving treatment for the condition. So there are a lot of times where, to be quite honest, in the course of a normal day, people might think about dying or dying by suicide even. And sometimes those are normal thoughts. But when they go in to go see a clinician, whether it's at the emergency room or their therapist, and they're describing distressing thoughts of that, and then thoughts that they might act on that, right? And then the clinician makes that determination. So basically, if it's serious enough to warrant further care or hospitalization, those are those numbers. So it's definitely not everybody with ideation. It's only the most serious cases. All right. Let's see here. All right. We'll kind of move on from there. So the syndromic surveillance paints a picture. And here's another putting the problem in context slide. And I really like this slide. Some of the numbers are a little bit older as of now, just because the data dashboards for some of these things take a while to update, right? And I also want to point out that the mental health disorders, 598 per 100,000 of population, that comes from those that access services. So that is not the entire number for every mental health disorder in the state. That is the number of folks that access services. But still, you can take a look at some of these numbers that we have 1,120 per 100,000 of population, uh, which is more than 1 in 100. Folks are experiencing suicidal ideation, hospitalizations due to suicide attempts. You can see how these compare to some of the other morbidities and mortalities that we face here in the state. So it really is a message that, as advocates for suicide prevention, need to be communicating the full scope and range of the problem. Deaths by suicide are only one part. The continued care for suicidality is a massive strain on our medical system. I have some data that shows that Arizona probably spent more than $300 million on suicidality in the hospital systems last year. And this is sort of how you can kind of see how that plays out and where it compares to some of the other conditions. Um, so the suicidal ideation and attempt-related hospitalizations are alarmingly high. So we need more community-based crisis interventions to help deal with this. The intersection of opioid use and suicidality in particular requires a dual approach. Um, and we need to get more training to our law enforcement and EMS, and have our response highlight a need for co-response models, mental health professionals and first responders, right? Because that can improve all of these outcomes. All right. So moving away from some of the data that we own, I'd like to introduce everyone to the Solari Crisis Response Dashboard. So this is data that Solari, our state contractor for our crisis system, makes available to everyone. So this dashboard provides a snapshot of Arizona's crisis response system. Some of the highlights on here are volume of calls, response times, and reasons for calling. Crisis lines are a critical resource, often serving as the first point of contact for individuals experiencing emotional distress or suicidal thoughts. The 30-day crisis call volume depicted here is 40,312, reflecting a very high demand for crisis support services. And as you can see too, if you look at the center top little graph there, statewide crisis volume by month, you can see that from November to January, we've had a significant increase in the amount of traffic coming into the crisis response system. We've also seen some big changes in the reasons for calling. So as we look at this slide here, which is depicting the statewide crisis system, this is not 988, this is our statewide crisis line. You can look at the top 3 reasons for calling, right? Social concerns, self-harm, suicidal thoughts, coordination of care. Uh, Pointing out that self-harm and suicidal thoughts are not the top reason people call our state crisis system. And if you sort of add up the other concerns, you'll see that self-harm and suicides are actually a minority compared to some of the other. If you add up sort of the mental health and behavioral health concerns, they're actually a larger chunk of the calls. Um, but one thing to point out is that psychosis, anxiety, depression, a lot of these mental health and environmental concerns, coordination of care, those percentages have all risen, especially anxiety. Anxiety, I don't believe, was even on the list here 6 months ago. So again, we can start to see the reflection in why the call volume is rising. We have a lot more calls coming in for anxiety and some of these other issues. Okay, one other thing that's important to highlight is there's a significant portion coming in, 12%, for coordination of care, suggesting that people are struggling to access the right services on their own. Right? And so as members of care systems and such, that means that we have to sort of improve the way that we handle our navigation and get folks to the help that they need, if that many people are calling because they don't know how to get to the right place. All right. So the mobile team dispatch volume has also remained stable. So while more people are calling, we can see that more people are getting stabilized over the phone. And when they can't, the mobile team dispatch is happening. So and actually, if you look at the course of the last 6 months to a year, mobile team dispatches have been decreasing. So that's an indication that our counselors have been able to meet more and more needs directly over the phone. So lots to look at there, but we'll go ahead and move on here to the 988 data slide. So there are some significant differences here, although you'll see self-harm and suicide is number one on this reason for calling list, right? And the call volume is much lower, but again, over the last 3 months, there's been a significant jump from about 5 or 6,000 calls over the 30 days to about 8,500 now. So, while 988 is the national suicide and crisis line, the state crisis line serves broader mental health and social concerns. And what the state crisis line is actually a reduction of all the old REBA crisis lines and individual lines that kind of permeated the state. And now we have the 844 534 HOPE number that's kind of that consolidation. So that's the reason why our state crisis system handles so much more volume than 988, because 988 is relatively newer. The key difference here, when you look at sort of the reasons why people are calling, is 988 is more specialized for suicide prevention and mental health crises, or at least that's the perception, and you can see that reflected in the reasons for calling. Whereas the state crisis line manages a wider range of crises, including care coordination, housing concerns, and substance use. All right, so 988 referrals are also overwhelmingly self-directed, where 71% are calling on their own behalf, where the state line has a lot of third-party referrals, such as from family, law enforcement, and from clinicians. Um, so another important piece that might not be teased out just by looking at is that 24% of 988 callers decline to provide their location information. And that's significantly higher than folks who are calling into the state line, which means that people who are calling into 988, one of the reasons why they're doing so is a higher perception of privacy. Right? There's maybe a perception that they're going to be their data is going to be more close held. So looking at it right now, 988 is emerging as specialized for suicide prevention in a lot of cases where the state crisis line is broader. All right. So one more thing on the wireless response when it comes to 988 in the state crisis line and such is geo routing is something that's really important to this. For a while with 988, we had this problem where if you were calling and you had an area code from another state, um, you would be directed to the call centers in that state. For instance, I have a Oregon State area code. So if I dial, I'm going to get connected to Oregon State's crisis services. Well, maybe that's important, maybe it's not, but if I need a crisis mobile dispatch, then that means I'm going to have to be transferred to my home state. So there are some instances where those out-of-state dialing codes were problematic. But because of privacy concerns, folks didn't want necessarily the GPS on their phone reading off their exact location when they call into a service like that. The fear being that, are they going to dispatch somebody and come and get me and take me away against my will? Right. So a good compromise to that is what's known as georouting, and that is what is depicted here. It's actually going into effect right now. Might even be in effect. I'd have to talk to our crisis system folks. This is an evolving situation. But the idea is that the location now when you call into 998 is coming off of the nearest cell phone tower as opposed to your exact location on your cell phone. So it's close enough to get a crisis mobile unit in the general area, but not close enough that they can get right to you without sort of the person walking them in on the location. So it meets the best of both worlds, and I'm glad that we were able to come up with this compromise because it really was affecting states, and Arizona with our high snowbird population. The out-of-state callers were definitely a problem here. Okay, what I'd like to do now is switch gears a little bit and get away from the data. The data is important for understanding the problem, but we've talked about the problem. So what are we doing about the problem? Um, Well, the suicide mortality review is one of two sources of data that we have um, for making the suicide prevention program sort of implement things, right? And so we have the micro level data that comes from reviewing individual cases of death by suicide, and then we combine that with our public health data that looks at population and trends. So both of those approaches are necessary, but a lot of times we gloss over this micro level detail and where that data comes from. So thought I'd take a minute here today to explain what our suicide mortality review system is, how it operates, um, because it's a little more complicated than the rest of our fatality reviews. Here on this slide, this flow chart though does a pretty good job of getting the high level stuff. You can see on the left there the ADHS block. That's us. And so we do a few different things here. We send, starting this year, an annual suicide mortality review report will be published and be sent to our decision makers. We also provide administrative support for our state SMR team, which I'll get to in a minute. And we provide funding and supervision for our individual county teams, our two counties that are reviewing multiple teams, our multiple counties, which we're referring to as our regional teams, and then also our veteran suicide mortality review, which is a specific population-based review for veteran deaths by suicide statewide. And it's the first such review in the entire nation, so we're sort of piloting that. The Arizona State SMR team is a little bit different, though, than those other teams. Those other teams review cases and sort of look for lessons learned and develop prevention recommendations that we then send upwards and outwards to everyone. The Arizona State SMR team is charged with not only supervising the county and regional teams depicted there, but for providing statewide guidance on death investigations that involve suicide. So if you think about the scope of that, that involves law enforcement, medical examiners, funeral directors. There's a lot of different points where the death investigations and sort of the death certificate process touch. And the state SMR team gives guidance to that. They also are in charge of awareness and education, analyzing and providing their own prevention recommendations, which you can see go then up there to those decision makers. So all in all, we have a pretty broad system here. It involves 13 different teams in three different categories of operations. So one really thing, really, the important thing is though, how does SMR develop prevention recommendations? So SMR examines deaths from a multi-system perspective, incorporating data from law enforcement, healthcare, behavioral health, and other sources. It identifies missed intervention opportunities, such as a lack of follow up after a previous attempt at suicide, or barriers to crisis care, or systemic issues like firearm access in high risk households. From these findings, the SMR team generates actionable prevention recommendations, which are then integrated into statewide suicide prevention initiatives through the Suicide Prevention Program. So SMR is not just about reviewing deaths, it's about learning from them to prevent future suicides. By analyzing common risk factors and intervention points, SMR creates tailored, evidence-based recommendations. And this helps us avoid the one-size-fits-all approach, which absolutely does not work for suicide prevention. These recommendations inform policies, funding priorities, and community-based information interventions, driving real change in suicide prevention efforts. So the SMR micro data plus the public health macro data, combining those approaches results in the best possible recommendations. They're more precise, they're evidence-based, there's stronger cross-sector collaborations between public health, law enforcement, healthcare, crisis services. And it allows us to get better at the implementation of these prevention strategies because we have involved all these folks and we do have them giving us advice and they have a seat at the table and buy-in. And so we're all working together and that makes all of this much better and have a much better outcome. So that's a little bit of an orientation to the work and kind of what the intent of it is. Um, Moving a little bit forward, we're going to talk about our cooperative agreement. So in August of 2024, ADHS, under the leadership of the Governor's Office of Youth, Faith, and Family, and in partnership with the Department of Veteran Services, and in collaboration with the Arizona Coalition for Military Families, we were all awarded the first cooperative agreement to expand suicide mortality review. Okay, we were one of two states, or I should say two programs, the other one being LA County. So we're the only statewide program um, awarded to expand. There were about 8 or 9 that were awarded to create. Right. And so many of these activities that we were awarded to do are specific to SMR, but I've chosen a few of them to go through because they're good examples of fatality work and just sort of underscore the process that I was talking about. And so understanding how specific data combines with the public health data to create the scalable solutions to reduce suicide, that's critical to understanding our state suicide prevention program because it all starts with SMR. So as part of our collective agreement activities, we're conducting monthly reviews of veteran deaths by suicide. This involves gathering those relevant records that I was talking about on the last slide and generating detailed case narratives to help us better understand those contributing factors. This work is current and ongoing, and we are scheduled to do our next review in March of 2025. One of the key outcomes here is that we were supposed to do one review during the award year, and we've completed 5 since then, holding them monthly. So that has allowed us to turn our attention to other things like postvention. Um, and this is important because while a lot of what we're talking about is focused on veterans, this is easily translatable to other populations. And so having a postvention guide for veterans means that 80% of the work is done for a postvention guide for other populations as well. So this postvention guide that's being developed, we're excited about it because it equips stakeholders with tools and strategies to effectively respond to and recover from loss by suicide. We've made significant progress with this, and we've even piloted it and done a couple of trainings with it so far, and there's been some satisfaction with it. So our current step is to be receiving feedback from those training sessions and our stakeholder partners and making it better. But that's another one of those activities that ties in with postvention is the follow-up care for those folks who have experienced suicidality. All right. So one of the things we're also looking to do is focusing on the development and implementation of training to improve coordination between the suicide mortality reviews and our offices of medical examiner. Right? We get a lot of our death investigation initial records and such from the OMEs, and we want to enhance the partnerships there to improve our data accuracy and operational collaboration. We're also piloting a 2-part toxicology upgrade for the offices of medical examiner, sort of trying to determine whether creating a pathway to our state hospital to do initial testing or creating awarding funding so that the county OMEs can go through their own private contracting for toxicology. We're sort of comparing those results and seeing which one is more cost effective. Um, we're also going to be assembling and distributing lethal means safety kits. Now, in the world of lethal means safety, firearm prevention is critical. 60% or more of our deaths by suicide are with the mechanism of a firearm. But fire or gun control, or sort of the traditional public approach to talking about firearms, doesn't lead to a reduction in that. So research has shown, though, that when you talk about things in a certain way, use the term firearm instead of gun, for instance, and you market things like hygiene kits instead of talking about gun locks and trigger locks and such like that, right, you can have more success. The way we're talking about this is that storing and securing your firearm, which there will be locks and a small storage safe that come with these kits. Um, that's the final step in proper maintenance. And for our veterans, there has been a maintenance process at some point during their military career. And putting the weapon away in the arms room and locking it up was the final step. So we're trying to draw the correlation between proper procedures and what you can do at home. We're trying to avoid the step of, hey, you don't know what you're doing with your firearm, please listen to us. We're just trying to remind folks that, hey, this is the proper procedure. And hopefully the difference in approach will give us some better results. Okay, now we're getting into some of our program updates as we round the corner here. Some important things to talk about. If you haven't already heard, we signed an IGA with Maricopa County to install a suicide prevention professional in Maricopa County. So they have a dedicated person there working for Maricopa County to partner with local organizations and implement recommendations from their Maricopa SMR. Um, this is going to allow them to increase community education and engagement because even though I live in Maricopa County with statewide efforts, I just can't get down to the grassroots level. So we felt that it was really important to have somebody here in Maricopa County that could do that, given that more than half of our deaths by suicide occur in one county. Couple other things that we've been up to. In conjunction with those organizations you see there listed, Access, ADHS, the Department of Ag, Farm Bureau, and University of Arizona, we have brought the AgriStress hotline to Arizona. You can see the phone number there. And this provides specialized crisis support with a specialized knowledge in agricultural, ranching, and farming culture. And so that's kind of what they advertise is they know how to speak to the rural needs and can help meet them. And so that's one step that we're taking to help meet the lack of services out in those rural areas. We've also awarded here just in the last week or two $1 million to Jewish Family Children's Services of Southern Arizona to provide counseling and community services. Some of those services include durable home medical equipment and grocery assistance, but they do a lot, and we're happy to support them down there in Southern Arizona. The area of award for that includes Graham, Greenlee, Cochise, Pima, Yuma. So those the border counties plus Graham and Greenlee. All right. We are finally winding up our other request for grant application, the one for suicide capacity and logistics building. It's been a long journey, more than 2 years now trying to get this thing across the finish line, but we've finally managed to give out 9 out of 10 awards, and we're finalizing the last one as we're talking right now. And you can see some of these organizations here, Speak Up, Stand Up, Save a Life, Team Lifeline, Impact, Arizona Youth Partnership, and some of these other ones. So we're starting to get all those contracts finalized, the kickoff meetings, purchase orders, and everything. So funds will start being distributed and the work will start going forward. And some of these projects will continue into 2026. So more to come as we get some report outs on what that work starts to look like. All right. Postvention, we talked a little bit about what's going on for veteran postvention. Well, here at ADHS, we've also been developing a postvention resource. Our intention is to make it comprehensive, as you see there on the slide, so that it not just includes educational environments, but also occupation-based prevention, faith-based postvention, and sort of family-based postvention. Talking about if we can put some guides in there for families to be able to talk about these things at home. Um, but our educational environment one is in draft. We've got K through 12 guidance and suggestions in there, as well as talking about college, university, and trade schools and the appendices, along with some of these other considerations like homeschool corrections and indigenous learning environments. So we're hoping to have that out sometime in the first or second quarter here. It's been a little bit delayed as we work with our graphic designer, but we will be finishing that up here in the first half of this year. Here's a little snippet of what it looks like. Just kind of the color palette there, and some of the things that we're talking about. So I put that in there so people can see it's not a chupacabra. It does exist, and we are going to get it out sooner rather than later. Last couple of updates here. Our 2025 suicide and self-inflicted injury report, the first one, which will include 2023 data, will be out here within the next month or two. I know a lot of folks have been excited because I've been kind of previewing some of the data that we're hoping to include in that. And so it will be our biggest and most thorough review that we've published yet. So we're going to hopefully be promoting that as soon as it's finalized. And another first for us is that this year we're going to be producing our first statewide suicide mortality review report. So there are some county-specific reports available from Maricopa, Pima, Cochise, but this will be the first time that we'll be publishing a statewide report with all consolidating all the lessons learned, all the prevention recommendations, and all the analysis from those various teams. I mentioned much earlier on the Garrett Lee Smith work going on in Cochise County. Here's a little snippet of what that work includes. Our partners for that are the Arizona Department of Education, the Intertribal Council of Arizona, and the Cochise County Health Department, as well as Office of Superintendent. So you can see we're going to try and increase the number of suicide prevention staff all over. We're going to increase the number of suicide prevention training programs in the schools. We're going to create a capacity to self-train so we can continue this training. And then there's going to be a universal response system implemented for every student that identifies as having some issues with suicidality. It's going to swoop in with a full care team, case management between the parents, school, and providers if that's necessary. And so we're really looking to pilot with this work what right looks like, and then to be able to bring that statewide. So we've seen some good indications that the work will be successful down there, and hopefully, given the current environment, it continues to proceed uninterrupted. And lastly, one thing that I always like to talk about is the opportunity for anyone who's interested to join in the work. And the best way to do that is through our disproportionately affected population work groups. You can see the ones that we have listed there. And these function as a community of practice where we get together and do some professional development and cross-promote each other's initiatives. And we also work on different initiatives to implement from the state plan. So if you're interested in getting together and working on some population-specific work, please reach out and get in touch with me, and I can connect you to that. Oop. All right, not quite sure how we're doing on time with the initial delay, but if we have time for question and answer, I can take some.
Yeah, absolutely. As long as you have the time for it. I don't see any questions in chat, but if you have a question, please feel free to put it in chat or raise your hand, and we can come off mute. A question that I have is, what are some things that we can do as direct service providers in bridging some of the gaps? So what are some of the gaps in services that you see around suicide prevention, that if our organizations are looking at how can we best help with the efforts that are already going on, or what services do we really need in this state but we don't have? What are some of the things that you see there in that gaps?
Yeah, absolutely. I think the biggest thing is that suicidality, there the way that we perceive suicidality really can open up a lot of gateways to additional help and services. Because when we think about suicidality, we make this connection consciously, unconsciously. Most people connect it to mental health. And looking at the data, I can say that mental health is only loosely correlated with suicidality. Okay. Now, a lot of people in the moment of crisis may qualify for a diagnosis, but 70% of those folks before that crisis and after that crisis, never qualified for a diagnosis, and they never will again, right? Suicidality, in other words, is more connected, much more connected to behavioral health and environment. And as providers and as clinicians, I'm a marriage and family therapist prior to this job, so I think in that term as well, right? As providers, we need to do more than just do the check the block of trying to refer our client or patient to more mental health therapy. We need to connect them to activities that improve their level of enjoyment in life, that improve their level of self-care, that also improve their behavioral health, right? And those types of things, a lot of that work can be done with peers, right? If they have good friends and social supports. And if they don't, then there are peer counselors that are available. There are work groups, or not work groups, support groups that are available online for this type of stuff. In other words, I'm trying to paint the picture that more therapy isn't necessarily the solution, right? And given the lack of providers and sort of the wait times for providers in the mental health space, maybe we need to be searching out some of these other avenues to help get people the assistance that they need.
I love that. Thank you. That's exactly, yeah, because that is, I think, when we talk about suicide prevention, it feels like such a heavy topic, right? And I think people are afraid to kind of delve into that, right? And see what our organizations can do when it really comes down to things as simple as connectedness, right? And what are some of the community ways that we can encourage the people, right, to become connected. We have the loneliness epidemic. We know, we've all seen the Surgeon General report. Arizona has done a lot of great work under the guidance of Nikki Gucci for the loneliness project and getting people connected in Arizona. So thank you, Josh. A question in the chat is, I'm curious if any studies have included religious affiliation. In other words, were any of these folks who committed or attempted involved in any spiritual belief organization?
Well, I would say that here, Arizona specific research into that question isn't available. We just haven't done that. But I can say at the national level, it has been done. And spiritual beliefs are an insulative factor, protective factor against risk for suicide. But it's not 100%. Nothing protects 100%. The biggest takeaway for suicide is there are folks who have spirituality and folks who don't. There are rich people and poor people and folks in the middle, people of every culture, every race. There doesn't seem to be outside of the particular risks, right? There's a wider or more narrower risk, but everybody is at risk for suicide. So, in other words, there aren't any safe communities where we shouldn't be looking. Right. And if we feel like, our faith community, everybody there is safe, then we're probably fooling ourselves. Right. And
Mm,
so, yes, it is an insulative factor, but I also want to highlight the fact that even in my old church community, over 5 years we had two people die by suicide. So it is
mhm.
something that occurs everywhere.
Yeah, thank you. Are there any other questions? Josh, will you be able to share your slides with us that we can share to the group?
Absolutely, I can send
Awesome.
these out, and then I will send them out with the slide notes as well, so you can get my speaking note.
Oh, thank you. Thank you. That's very kind of you. Thank you so much for coming and presenting, even with your very dysregulating morning of, trying to get in. I'm glad that the technology gods have allowed like this to happen. I feel like technology is almost as done with us as we are with it, and it has its own personality. So I'm glad that it allowed for this to happen. But I thank you so much for coming in. This is such an important topic. And I think there's so many ways that even just us as humans in this world can really assist, right? And when it comes down to, prevention is around being connected. How are we with everybody in our community, right? Are we kind? when we're out, we know we all are out in the public, and we know that society has become increasingly more dysregulated, right? And so our self-regulation is so important in those spaces. And I am just as guilty as anyone, right? Being human, and going into Walmart is like my one space of like, okay, what are the processes I need to do in order for me to stay, right, the most regulated, so I can be kind, because we never do know what somebody else is experiencing in their life. So I appreciate all of the work that you all have been doing. And if anyone has any questions, Josh put his email in there or wants to get connected. He does really, really great work at the state level for suicide prevention. And I mean, like, really, really great work. So please connect with him if he can help. Thank you again, Josh.
Well, thank you for having me, and thank you, everyone, and happy Thursday.
Yes, happy, what is Sandy says, Friday Eve. We're getting ready for the weekend. All right, so we will move on to our committee and partner updates. I have to see if some of our committee chairs are able to be in here. If not, so Jennifer is not able to be here right now, but the trauma sensitive schools work group still meets on the first Wednesday of the month, virtually from 4 to 5:30 p.m. I will put the link in the chat if you'd like to register for the recurring Zoom meeting that they have. She brings in fantastic speakers. And as always, all of their recordings are also on the trauma sensitive schools work group page, which I will add into the chat as well. Renee, I know you needed to leave. I'm not sure if you are still here, if you had to jump out. She had to jump out at 10. Renee is chair of our rural and indigenous subgroup, our work group, and she said that they have been having presentations by the Coconino Coalition for Children and Youth and First Things First. Both presentations focused on sharing statewide resources and tribal resources. Her recordings of their work group are also on their work group page. And so if you've missed anything, you can always go back and I can put her email address if you are interested in joining that group. Sabrina, I don't mean to call on you as soon as you come back to sit down. Are you ready though for the communications?
Yes, my dog is barking. I'm trying to get her to stop.
No
like,
worries.
Right? You haven't barked this whole time, of course.
Always. Murphy's Law. We're good.
I ran over. I was like, stop barking. Yeah. Yeah, no, thank you. So I am the communications chair. We have some really exciting stuff that we're working on this new year. We met in person recently. We'd like to meet in person once every other couple months if we could, but we are meeting virtually, and so we are welcoming new members all the time. We're a pretty small group, but we'd love to have anybody join us if you're interested. We are creating still some updates on the newsletter. In the next couple months, you will receive a link that is going to go out on the newsletter. And then I'm going to be probably working together with Angie to get that out to everybody else. It's going to be a brief survey just to kind of get insight on what you want to see in the newsletter. We really want to hear from you. Just what is something that you look forward to seeing that you already see in there, or what is something that you want to see in there in the future? It would be like a 5-question survey. Right now we're just going through some data analysis that Angie was able to send to us and come up with that. I do have, though, a survey link that I'd like to put in the chat for any committee members that are here, but it sounds like there's not that many that are here right now, because as you know, we do highlight committee members in our newsletter as well. We highlight committees and updates that's going on, things that we want to make sure that we address that. So I do have a link, but Angie, it sounds like none of the committee members are here, so I don't want to put it in the chat.
Well, we're only missing 2 of them, but I can send it to me and I will send it out to all the committee members. I mean,
fantastic.
Yeah.
Fantastic. And then beyond that, we're just working on kind of growing what we're able to offer and what we're able to do. So like I said, if you are interested in joining our group, reach out to me directly. I'm going to put my information in the chat as well. And then I think that's the only updates that I have.
Those are great updates.
Yeah.
Thank you, Sabrina. Thank you. Sandy?
Sabrina, I had to wrangle my dog out of the office before we even started, because he historically does the same thing. Quiet the whole time until I go off on camera. Good morning, everyone. I am the chair of what we have now renamed to more accurately reflect the work that we're doing is the trainer support work group. So way back in, what was it, 2016, 2016, 2015, when the work group started, the primary focus was creating the curriculum for the Train the Trainer. And since we now have that curriculum, we have shifted to really looking at how we can support our certified trainers across the state. So we are now meeting quarterly. Our first meeting was yesterday. If you are a certified trainer and you would like to join us, if you have some ideas about trainer support, or if you'd like to, help us support trainers, go ahead and email me. Our focus, what we talked about yesterday, is our focus for the first part of the year, quarter one and quarter two. We will absolutely continue our quarterly community of practice for certified trainers. Our next one is scheduled for, or I should say our first one is scheduled for Thursday, March 20th. And I can't talk and do things at the same, anything else at the same time. So it's Thursday, March 20th from 1 to 3. The link to register is in the chat. I will also be sending an email out to all of our certified trainers as well. So focusing on bringing everybody together quarterly. Our surveys from our communities of practice tell us that you all really love being together, networking, being in breakout rooms. We're not going to do much with changing the format, which is generally some form of trainer development, and then a lot of time spent in breakouts, talking with your peers and exchanging information and all that good stuff. The other thing that we will be doing, and we are just creating the foundation for it, is individual support for certified trainers. Last year, we sent out on the survey a question about coaching or individual one-on-one support. Lots of trainers said if it was available, they would use it. Currently, we do it pretty informally, which amounts to just Angie and I responding to any trainer questions that come up, but we'd like to do it in a more coordinated way. I will tell you right now what it looks like. It doesn't necessarily mean this is how it will play out. But on what we talked about in our work group was members volunteering once a quarter for a couple of hours. Hopefully that means we can, on a monthly basis, provide a link to office hours. So certified trainers can just pop in. And if you have questions or you're, whatever you're looking for, it really would be on a pop-in basis. So that's kind of what it's looking like now. But obviously, when we get some structure around it and we have it all figured out, we will be sending that out to our certified trainer group. And then sometime middle to end of March, beginning of April, we will send out our annual certified trainer survey to get your thoughts and feedback about the things that you are needing support for. So that's it for us.
Thank you. And I love the direction that the training work group has gone with our trainer support. We now have over 500 certified ACEs trainers, and that number keeps growing every year. So very exciting. Sang-Hoon?
Okay. All right, hello everyone. Heng here for the interface committee, and I just to put on the chat about my information, and also I want to highlight Robin Blumenthal, my superstar hero, especially in Tucson area. So she has been very faithful doing the work as a director there of our Asian Trauma Informed Faith Coalition. So yeah, just contact her if you're in that area. And Robin, if I put the wrong or if you have a better email, you can put your email in another email in the chat, and you can see that Facebook City and Consortium Interface Committee and Coalition and Weave and Cleave Conference and Movement is pretty much in the same platform. It got more specified later, but pretty much I'm the one kind of coordinate the things. So this is a report for the committee, but also all kind of interconnected together. And just the best way to be involved in the committee, email to me so we can kind of coordinate and work together. And faith community is always embedded. So it's going to be interesting and how we're interacting together, because in our gathering, you see everyone. You see that from the government and school system, because, like Josh said, if you have a faith and you're a teacher, you can be both, so it's all kind of interconnected. And so it's hard to kind of sort it out, what is about faith. And I like that idea though also. What was that? The suicidal attempt or prevention. And I think Denise was asking about the faith community kind of involvement. And so even anyone have any kind of a question on that, just to let me know. As Josh said, I'm Maricopa County Suicide and Mortality Review Board. So might be I'm the only pastor out of those about 20 experts, but yeah, there's no category about the faith. Recently, we have a category about ACEs, so we can see that all the suicide, the cases, the ACEs is on there. And I try to advocate we should put in the protective factor if we can to the surveillance work, but at the same time, faith is very, very involved, and you can see also a lot of faith-based service organizations, which we are covering too. So it's a very broad concept. At the same time, in Arizona, that the school teachers' suicide is high. And I was speaker at the couple of weeks ago. There was a national conference here in Phoenix about church trauma. So there's a religious trauma and church trauma. So church is not only, or the faith community is not only the supportive faith, the factor, right? The protective factor. Sometimes people get horribly treated at the church or faith community. So that's another kind of a huge kind of a focus of our group, our work too. And so with that, I put the Weave and Clear podcast. Actually, this is kind of our bragging of our consortium, because Asian Trauma Informed Faith Community or a coalition is born in our consortium. And as a part of the interfaith community activity, we started a podcast about 3 years ago. Angie was guest, and a lot of people were guests. And so if you try to find any podcast platform, the Facebook City or Weave and Cleave, Weave and Cleave, you can see there's two sections. One is Journey On. So I brought all our movement stars in our state as a podcast guest, and there's a Journey On episodes. And since last year, we started Weave and Cleave podcast episode. And so far we have about 40 episodes and more than 3,000 downloads. I mean, it's not a big number, there are about 4.4 million podcasts in around the world. But if you have above 25 downloads regularly, you are kind of a top 50%. And our podcast has about 40, 45, 50 downloads regularly. So we have a good impact, and many of people come to get to know about ACEs and trauma-informed care, and they be a part of a consortium, and then they be a part of our TOT training. So that's kind of beautiful work. So I'm very proud of our consortium interface community, what we started. By the way, next guest, we will drop, yesterday we dropped Manzi Lori. She is a counselor, also she is a refuge survivor. Next month, we do the twice months we drop the podcast. So March 5th is gonna be Galen Elmore. And he was keynote speaker last year's prevention child abuse, Arizona. And then guess what? Paula was there and then said, "Hey, Sang-Eun, there's one guy speaks the same language with you." And so she tried to connect me with the Galen. Galen is a really national star on this, talking about foster care system and also the trauma and the resilience. But people might know, I know him personally in other personal connection, and his faith is core. So in our podcast, you can see that how his faith is connected of his work and his resilience. So those are beautiful things, and you can see that how the spirituality, as Josh said, spirituality, not organization, but spirituality and also their resilience can work together. Breakfast. So ACES Consortium sponsored last year's breakfast, and that was another our interface committee project. So it started that way last year, and we had Bob as our guest speaker there. And this year it happened, and it's a more bigger size, 120 people, and from everywhere. And then Josh worked with Dr. Bin Saw. She was also one of the speaker. And how do I know Bean? Well, she was my church member before. Again, let me tell you, it's kind of a connection there. And also we had out of 15 panelists and speakers, we had Melinda Kulik, the CEO of the First Things First. And guess what? She solely talked about her personal story, how the faith got engaged with her personal story that end up her position at the CEO and First Things First. So it was very powerful time, and as a breakfast, people can see the government and private sectors and faith community, all others can coming together. And then Community Belonging Project is our grant awarded project from the County Public Health, and we continue the 6-hour whole training. And so there's the training gonna happen on Grace International Church and Huntington University, Arizona. Some organizations open their training to the public, some are not. So what I marked here is open to the public. And we're gonna share the registration link pretty soon. But I didn't make the registration yet. However, I want to more talk about our third Weave and Cleaver conference. Also, ACES Consortium is a huge sponsor on this, and have the table, the exhibit table there. And this year, same place, Desert Willows Center, and there's the link there is a free, and it's all day. And we have about 8 speakers from other states. And then we have a Rick Griffin and about 30 speakers from local. And Angie said, "Oh, I can stop by and speak." So I'm trying to arrange that out of 50, we have a 51 right now. So in one day, I don't know how we can handle 51 speakers, but anyway, we'll try. But you can see that the atmosphere is really building safe community. from people everywhere. Sometimes maybe you don't want to get along, but the major thing about conference is that how we can build a safe community relationship, so we can build a community belonging from everywhere. People are not going to be corrected first, but connected first. So connection, yeah, before correction. And then people are going to really share their struggle in compassion, and also build a resilience, hope together for the future journey together. And we have people from all kinds of sectors, and then they have also a side of faith, like Melinda Glick from the First Things First. So you will see a beautiful and powerful the gathering. And so I really recommend to join and come to our conference in April 23rd. All right, so if you have any questions, just let me know, and you can email me anytime. Thank you.
Thank you, Sang-hoon. I always love your share. You do so much all the time, and I'm glad that we can act as a connector to the work that you do. One of our other partners, our Southern Arizona Trauma Informed Network, they weren't able to be here, but big, huge thanks to them, especially the banner staff, Alice and Hillary and Jennifer, and all of the work that they did to host our summit watch parties that we had this past year at the last summit. It was really great to have kind of in-person pieces in some of the rural areas that we don't able to get connected with. In their chat, I put a way to stay connected to them if you are in Southern Arizona. So just a couple quick board updates is one, welcome to our new board member, Lizzie Rasmussen. She just came on as our newest board member, and we're very excited for her to get started. If you were at the summit and watched her presentation on building resilience and the physiological factors of it, she is amazing. She is also going to be our speaker at our next mental health well-being community of practice, which is April 30th from 10 to 12 p.m. I'm going to put the link to register for that in the chat. So she will kind of present on the physiological aspects of building resilience, right? What that can look like. And then we'll do small group breakouts. We have fun at our mental health and well-being community of practice. You know, Sandy and I were not super strict and on time. It's more of a conversational piece. We do still have one board opening. We are looking for individuals who have experience in fundraising, business development, and or are a physician. Physicians are really hard for us to keep on our board because, well, y'all are incredibly busy. And so if you know of anyone, if you are interested, please reach out to me and I can get you a board application. I can answer any questions that they have of what board participation looks like for them. All right. Moving on to some of our announcements. You may have seen in the emails that have gone out recently that we have scholarships for our Resilience Empowerment Project training of trainers for people outside of Maricopa County. So we were really fortunate to receive a grant from Vitalist Health to take the project that we have been doing in Maricopa County for the last 3 years and look at how does this look like replicating and expanding it across the state of Arizona. The training itself is all going to be virtual, and you will receive curriculum on our 3-year program with our schools, our curriculum that we have for community organizations, direct serving, and also indirect serving. We have our youth training, and then our combination group home staff and youth, and then the parents and the caregivers and youth. So that is like one big, large community-wide project, right? Like, how do we look at all of these different sectors when it comes to understanding ACEs and the impacts of trauma-informed care and building resilience in our communities, right? This has that curriculum that looks at all of them. So if you are interested in applying, if you're outside of Maricopa County and interested in bringing it to your county, we have space for 1 to 2 members of each county to be trained in the rep material as a scholarship. And I will put that information in the chat in a second. And then our second opportunity is we are doing a pilot of our youth resilience program, training of the trainers. So we have, this is an in-person training. It's going to be April 1st from 9 a.m. to 4 p.m. It will be held in Mesa, and we have a really limited, we're looking at like 10 to 12 people, no more, to do the first training of the trainer for our youth resilience program. That cost is $399, and we do not have scholarships available for this training. I have all of the information on the website, though. Let me put this in the chat, where you can get information on the curriculum itself. You can download the scholarship application, not the scholarship, the application to apply to be one of the positions, one of the opportunities that we have, and just more information on the youth program in general. Are there any questions on either of those two opportunities before I move forward and kind of ask about the summit? Oh, and applications for both of those are due Friday, March 7th. So we are about two and a half weeks out for that. Okay, if you are typing, please continue typing, or you could always just reach out directly to me. So our 12th annual ACEs and Resilience Summit. Like I said at the beginning, I really want to get your guys' feedback, because I want to bring, the summit is a lot of work, and by a lot, I mean a lot of work. And I don't want to put in all of that work if it's not something that you all actually want. And so I'd love to have your feedback. Feel free to come off mute, put it in the chat. Actually, maybe putting in the chat works best, because then I can download it and have that. But what are your thoughts for one, what we should focus on, right? Do we want to do some regional in-person watch parties like we did last year? So I'm going to put this in the chat. Regional watch parties, yes or no? And so that way I have that kind of delineated. But in the chat, what are your thoughts? Do you think that is something you would like to attend? When I should say, if you're saying yes, put your region as well. Mike, I know yours. Because that makes a difference, because maybe we're going to the wrong regions as well. Okay, and then looking at the structure of the summit. Currently, what we have been doing is we have our Resilient Schools Conference the first day, our Medical Professionals Conference the second day, and then our the technical 12th annual ACEs and Resilience Summit, right, for those 2 days, which really focus on ACEs and trauma-informed care and all of those pieces, right? We've had a very we've had a very strong theme of communities and what community building and those pieces look like. The question to you all is, if we think it would be more beneficial to have sector specific days. So for example, we have the schools, we have the medical professional, those stay, right? But do the other 2 days, or even more, 3 days, depending on the structure that we do it, would you all like to see sector specific days or like theme specific days? So for example, criminal justice, like one whole entire day just focused on kind of a criminal justice summit around ACEs and trauma informed care, or youth, or suicide prevention, or substance use disorder. Like, what are our thoughts? What are something that you would like, oh, if we could create this is what, it would be really great to have, this. What does that look like for you all? What are your thoughts on those?
Angie, would you prefer to have us to put it in the chat, or
You can do either, because I'm taking notes on a Google Doc as well. So
I just wanted to provide some feedback on
yeah.
that. I think that coming from a different lens, and obviously I'm usually I think this past year is a facilitator rather than an attendee. But I think that sometimes it's hard when all of the same topics are done on the same day, because it's like, ooh, which one do I choose, right? Like, where should I go? So I like it widespread. I think that was what a couple of people actually told me when they attended a couple and I facilitated, that they were just like, oh, I don't even know where to go. Or there was so much that went to one topic that was like heightened, right? That others only had, like, unfortunately, 4 people in their group. And then the presenters were like, well, I love presenting to a small group, but I was hopeful that there would be more. So, that was just a little bit of the feedback that I got, just attending those as a facilitator, as a person that was running those Zoom groups, and so forth.
Thank you. Thank you, Sabrina.
Angie.
Yeah. Hi, Teresa.
Hey, Angie, can you hear me?
Yep.
So one thought that came to my mind, because I was presenting, I was able to go into, the other ones. And oh my God, I went into some of the medical ones, and there's so much that I learned, just from that perspective. So me being able to see the other options was awesome, because I got a lot out of that, versus if I stayed in my own field, I was sort of familiar with a lot of it. I don't know if that makes sense.
Yeah.
But I was happy to have the opportunity to be able to pick and choose.
Yeah.
And so that's just my thought on that. So I guess it goes along with what Sabrina was saying. It's the being able to go into more general ones, I think. I don't know. Thank you.
Yeah. Thank you. Yeah. Taisha says, I believe it'd be helpful to have themed sector days. And Tatiana says, I like the spread over sector days, helps me digest it better. And yeah, and maybe it is themed sector days where there's a couple different tracks as well. So, if we're looking at those pieces. Virginia?
Hey, just my personal thoughts. I personally don't like the theme and sector days. I think it's dividing folks into silos, and I agree with Teresa. Some of the best talks I go into or might be on this day or that day, and if you're thinking, oh, I've got to be there for my sector day, you might miss some of that information. I do imagine it's easier with your marketing to like get doctors on the doctor day. So I'm not saying necessarily if there's reasons you have the ones you already have, I don't think they have to go, but I wouldn't necessarily if it was me, I wouldn't put a lot of effort into creating new ones.
Okay, thank you. Thank you. Yeah, I asked because our sector days actually, like our schools day, which schools and medical professional days, they have been add-ons as we have grown. And we actually have better registration and attendance for those than we do for the last 2 days. Part of that also though is because there's no cost to those days, right? And we do understand that cost can be a factor, but I also I want to bring something that is something that you all would like to participate in as well, right? So for example, our quarterly meeting here, and I'm just going to be completely transparent, our quarterly meeting registration is 92. The registration that we had for the full entire summit was 125. So you can see that I don't feel like we are serving as many people as we can. And so just trying to figure out what is it that that you would like to see, right? And maybe we can adjust and change some of the pieces. So then the next question is do you like things all in 1 week like we currently have it, right? We go Monday through Thursday, it's all week, it's one and done. For me at least, right? I'd rather just take the week out because for me and my workload, it works best. But is that also too much strain on attendees to have 4 days in a row that they are attending things virtually? I know that it also can be a lot because by the end of the summit, I am wiped and I usually need to take a good 4 or 5 days to kind of decompress from all of that information that I have had. So, for you all time wise, would keeping it all in 1 week or looking at it spread over, a few weeks or, a couple months, like once a week kind of piece to it. April?
Yes, good morning.
Good morning.
I was just gonna chat you sort of back to the previous question. 4 days is a lot. It's a lot to be able to take away from the office. But as you're talking, I'm just wondering if maybe you do 2 days of theme 1 week, and then maybe a couple weeks later do 2 days of general, or alternate them. So maybe you're doing them quarterly. You do the theme 1 quarter and the, or however, but 4 days is a lot for you too.
Yeah.
So I would think you wouldn't want to do like one every week. So I'm thinking maybe 2 days one time and then 2 days another time might be a little easier.
Yeah, that's a good idea. Thank you, April. Any other thoughts? This really does help me. I appreciate it. Virginia?
Sorry.
Okay.
Angie, I think all the work you do is beautiful. So take or leave whatever I say. One of the things I was thinking is there's some real, you're finding these national speakers, these folks that overhaul this or that. There's a piece of me that's wondering if it's grown too big because there's so much content. And if we got down to like a 1 day of this big speaker, this big initiative, this and it was just kind of like this really big 1 day of the breaking news and the best of the best. I'm wondering how that would feel. It's tricky because I know you're trying to get we try to keep getting the rest of the state newbies to ACEs and stuff. So they might not necessarily start at the cutting edge, and they might want to start it with what is the ACEs study. So I don't know if there's like a beginner's day type thing, and then like the big, like, you guys have been doing this work for decades. Here's like the cutting edge or, I don't know. I'm just trying to think outside the box a little.
Yeah. Yeah, I concur. And I'd also like to start highlighting more of our Arizona specific. So I have focused right on bringing some national speakers in that I really think make us think, right? Kind of expand our thoughts and our awareness pieces to it. But also there's a lot of work that's being done in Arizona. And would love to, maybe highlight those things. Okay, this has given me a lot to think about. Thank you. It is February, and so by our next board meeting, which is in March, we wanted to have just some feedback from you all, right? Of what that looks like. I might, in addition, send out a survey link to those who have already participated in our summit. And then in the follow-up email to this, just to gather some more data from all of you. So if you think of something, you just didn't want to share it in public, I completely and totally get that. Please feel free to reach out to me, because I really do want to bring things that are beneficial to you all and things that you want to participate in, right? And I'm not afraid to redo things and to restructure activities and those things, because if it's going to benefit you all, then that's what I'd like to do. So as we close up, just for your calendars, our 2025 training and events so far, we have our Youth Resilience Taught on April 1st. Our Mental Health and Wellbeing Community of Practice is actually April 30th, and I have a misprint on there. And then our next quarterly meetings, which if you are registered for this one, you are registered for them all, May 15th, August 21st, and November 14th. If you would like to speak at one of our upcoming quarterly meetings, please reach out to me and we will get you scheduled. Our social media link, please follow us on there. I will put that in there. That page links to all of the different social media we have, so we don't have to share each link individually. And now I would love to take this space for any new business or anything that is going around the state that you would like to share with our members. It will go into our follow-up email, so definitely will be more than just our members who are still here with us right now. You can feel free to share it in the chat, or I'm taking notes, either way. Leslie?
Good morning. I just want to throw these out there because all of you are welcome. We've got a couple spotlights coming up. So the National Resilience Community of Practice that I host, this beautiful offshoot that has happened, is these spotlights, which provides these state leaders who are doing amazing work in the world of trauma responsive, trauma informed practices, and also social emotional skill building. And so it's for educator settings, anyone who works with youth settings, and these spotlights are all free and they're virtual. And I have really attempted to keep them brief and short. And so anyone that wants to just pop in, you can pop in. We've got when our next one is this Monday. It's Leading Transformative Mental Health in Schools. A couple professors who are doing some amazing work out of Boston, who are going to talk about what they're doing and what it could look like if we were to do that work here. So I think that's the important thing, is how we bring that back here. And then our last two presenters are actually local. So they're from Arizona. We've got somebody from U of A, a professor, and then Jim Bach from out of Florence. And he is finishing up his doctorate, and he's talking about increasing social emotional capacity for adults, which is so needed right now. So any of those that look good, that link will get you into all of them. So I want to put that invite out.
Thank you, Leslie. That's awesome. I love that they're short too. Talk about listening to the community, right? We got 30 minutes. Yeah, I love it. And then Sabrina also put in the chat that Dr. Ina Hilgers is hosting a 2-day heart math training in April. If anyone is interested in gaining access, there are only 20 seats available. This clinical intervention really links the body/mind, a key to healing through a trauma-informed approach. And then the link for the flyer to the training is there as well. Anyone else have things that they'd like to share with our members? Oh, and Cheryl shared that the San Carlos Unified School District number 20 is hosting their annual Journey to, I don't want to mispronounce it, Cheryl, conference held at the Apache Gold Convention Center on April 23rd to the 24th, and it is open to the public. Cheryl, can I just share your email with the members so they can reach out for more information? Awesome. I will put that in the follow-up. All right. Anyone else? Well, thank you all for taking time to join us this morning. I do appreciate it. I know that 2 hours is a long time. And I appreciate you being in this space with us. Of course, if you need anything, please reach out. If you would like to share any kind of upcoming events or those things, please reach out to Sabrina and have her put it in the newsletter. They do amazing work of getting so much information into just 2 pages for it. And we hope you all have a great Friday Eve. We're almost there to the weekend. Thank you all.